Are you nostalgic for the quizzes of yesteryear, the ones that sparked self-reflection or even a little action? I've got the quiz for you. But this time, it's not about finding your perfect lipstick shade. It's about safeguarding your brain health. Head over to www.rootcausology.com/quiz to embark on your brain health journey. And if you're yearning for those other quizzes, you can probably check one out the next time you're in line at the grocery store. Hello and welcome to Get to the Root of It. I am your host, Laurel Brennan, and very excited to welcome Dr. Mark Davis today. Hi, Mark.
Hello.
So Dr. Davis received his doctorate of naturopathic medicine with honors in research from National University of Natural Medicine, and he is a fellow of the American Board of Naturopathic Gastroenterology. He is faculty at Sonoran University of Health Sciences and former ranked faculty at Maryland University of Integrative Health, a founder of board member of the Gastroenterology Association of Naturopathic Physicians, and on the editorial board of the Natural Medicine Journal. So welcome again, Dr. Mark Davis. Can you tell us a little bit about you?
So as obvious from my bio, I love natural medicine. I love naturopathic gastroenterology, and my patients all have gut things for the most part for me to think about. Most of them have inflammatory bowel disease, and excited also in general in my life about evidence-based medicine, evidence-informed medicine, and how we use evidence to make clinical decisions. So those are kind of my loves and how they intersect professionally.
Yeah. Awesome. So for someone who might not know what IBD is, they may get it confused with IBS. Can you explain the difference between the two?
I remember before I went to naturopathic medical school, I confused the two. And maybe even in my first year, I had a patient with IBD who I was like, oh, I know what that is, IBS. So, of course, the initials sound very similar. IBS, that is not my specialty, is irritable bowel syndrome. By its current definition, about 4% of people in the United States have it, although by the definition just before that, the definition is reassessed every 10 years, 9% of people have it. And some people still use that old definition. So it's very common. It's a functional disease, which means we can't look at the tissues and find any detectable organic changes that explain the reason for why people have the symptoms they do. That's irritable bowel syndrome, and it consists of changes in stool frequency and consistency and abdominal discomfort and stuff like that. But there's no changes to the tissues that we can measure. So I've worked with plenty of people with IBS because it's so common, but it's not my specialty. My specialty is IBD, which is inflammatory bowel disease. And there's two major kinds, which are my specialties: ulcerative colitis and Crohn's disease. There's a couple of what we call minor kinds that I don't specialize in. One is microscopic colitis. And I've worked with microscopic colitis patients. In fact, I really enjoy it, but they're not my specialty. I've only worked maybe a dozen instead of hundreds. And the other one is Behçet's, which is I've never seen a patient with it. It's very common in people with like Silk Road ancestry, Iran, Turkey, that kind of thing. But I've never seen a patient with Behçet's. So that's inflammatory bowel disease. And instead of 4% of people having it, 4 to 9%, 0.4% of people have ulcerative colitis and Crohn's in the United States. And it's not a functional condition. It's a named disease, and there are detectable changes in the tissues. We can see infiltrations of white blood cells into the tissues. We can look at and measure inflammation amounts in the cells. In fact, we can often, when we do colonoscopy or upper endoscopy, visually see redness, inflammation, swelling, ulcerations in ulcerative colitis and Crohn's. The ulcerations in Crohn's get so deep that they can cause fistulas or little tunnels from one organ system to another. And that is a condition where people sometimes need blood transfusions because they're losing so much blood rectally. Sometimes they need IV fluids so they don't get dangerously dehydrated. And I think it's about 40% of people with ulcerative colitis eventually need some surgeries to surgically remove parts of damaged tissue. And about 75% of people with Crohn's eventually need some surgeries to remove tissues. So that's the difference between them. One is very common and can really affect quality of life, but doesn't really need surgeries or hospitalizations. And the other is much less common, about 10% the rate, but more dangerous to an individual.
Right. So, but they might start out similarly with
Sure.
bowel discomfort, change in your stool, constipation, diarrhea, pain.
Absolutely,
Yes.
100%. Although the new definition of IBS does not include pain. That's why so many fewer people have it. Or I'm sorry, it only includes pain, not discomfort.
Oh.
So yeah, you have to have pain as a criterion, but abdominal discomfort used to be one of the old criteria. So right, those, and very often IBD is initially misdiagnosed as IBS, and it can be misdiagnosed that way for years at a time sometimes. So yeah, very often the picture starts out very similarly and they can be hard to tell apart.
And is it possible that if IBS is not addressed, that it could lead to IBD? What are the connections or relationships there?
Well, no, they're really distinct entities. And in fact, you can have both at the same time. So there's times when we're working with patients with inflammatory bowel disease, ulcerative colitis or Crohn's, and where we can measure the inflammation levels very well. And they're very sick and we get them better until they're not bleeding. Their inflammation levels are normal in their stool and in their blood. We've gotten all their markers normal, but they're still having abdominal pain or stool frequency or something like that. And then we call that the IBS within the IBD. So somebody can have both of those diagnoses at once. So yeah, IBS doesn't really lead to IBD. They're separate tracks that look like each other and can coexist.
Okay. And do we know what could cause IBD? Are there?
Yes. So there are about 150 or 200 different genetic contributors, but it's not a simple genetic correlation like some clearly genetic diseases are, like cystic fibrosis or breast cancer that's secondary to BRCA or something like that. There's some very simple genetic conditions, and this is one that does have genetic involvement. First-degree family members are more likely to have IBD than non-first-degree family members, and we've tracked down 150 or 200 genes that are related. So there is a genetic predisposition. Now, many people with that set of genetic predispositions do not go on to get inflammatory bowel disease. So you can have the predisposition and not get it. So what else is in there? Of course, what's left is your environment, your activities of daily life, your microbiome, your gut microbiome. So those are the things that play into it. And we know that there are some things like women who take probiotics or eat fermented foods while they're pregnant are less likely to have kids with inflammatory bowel disease. Moms who have more exposure to different types of microbiomes through encountering pets, large human families in the household, working with farm animals, that type of exposure to different microbiomes also reduces levels of really autoimmunity in general, but specifically IBD. So certain trigger. Oh, and then very often my patients tell the story, and this is in the literature too. I was traveling to Latin America or Southeast Asia or somewhere else, and the party I was with got gastroenteritis. We all got sick with diarrhea and pain and stuff like that, and everybody else got better, and I didn't. So with any autoimmune condition, the problem is your own immune system wreaking havoc on your body tissues. And with IBD in particular, your immune system gets activated. Oh, there's a problem that I need to fix. Maybe it's a gastroenteritis. And it starts to attack what it thinks the problem is. And then it can't slow down. It can't go back to a state where it's being tolerant. And it keeps attacking, being triggered by normal gut flora or our own tissues or something like that. So nobody really knows 100% what is triggering it. But the general theory is it's something about our own gut flora that makes somebody who's predisposed be in permanent attack mode with their immune system in the gut.
Okay, thank you.
Yeah.
So to differentiate again between IBS and IBD, IBS is not autoimmune and
Correct.
IBD is an autoimmune disease where your body's attacking itself.
Yeah. Not to get too deep into the nitty gritty,
Okay.
but over the past decade, researchers are starting to build a case that IBS may be an autoimmune enteritis too, where we develop antibodies to something called cytolethal distending toxin produced by certain bacteria that looks like a certain cell type in the small bowel. So there may be an autoimmune component to IBS, but researchers are even less in consensus about that particular fact.
Okay. Yes. That's very interesting. I'm interested in the development of that research.
Yes.
Because as some of the listeners are aware, I have multiple sclerosis, and I definitely had IBS for years before my MS diagnosis. And I hear the same for Parkinson's and
Sure.
Many other autoimmune diseases as well, that there was some gut issues first.
Yeah, there is pretty clearly in the literature a neurodegenerative microbiome. And I know for Parkinson's in particular, we can measure those, usually find those changes in microbiome about an average of 6 years before symptoms start. So the microbiome changes happen first and the neurodegenerative changes happen second.
Super interesting. Okay,
Yeah.
so how can the gut impact the rest of the body and the brain in particular?
That is a great question. They seem so far away from each other, like they're doing completely different things. And there's basically two ways, through the nervous system and through the blood. Those are the two main ways. And the nervous system is basically via my favorite of the cranial nerves, cranial nerve 10, Roman numeral X, the vagus nerve. Vagus is Latin for wandering, like a vagrant wanders through town. Because of the cranial nerves that go right from the brain to certain organ systems, it is the most wandery about. It innervates a bunch of major organ systems, including the gut, and it has two-way communication, brain directly to gut and gut directly to brain. And we have a lot of information from animal studies and human studies that what happens in the gut in terms of the gut microbiome and inflammation levels in the gut sends nerves through or sends messages through the vagal nerve to the brain that then impacts many things about the immune system and neurological activity and other things. So for example, you can take mice that are very anxious, and if you give them probiotics, it statistically significantly reduces that anxiety. But if you take mice that are anxious and you cut the vagus nerve and then give them probiotics, it does not reduce their anxiety at all. So, so we have a lot of interesting information from animal studies like that and some human studies that the vagus nerve is sending information from the gut to the brain that is affecting cognitive ability and neurological activity. The second way is through the blood. And there's a lot of things that can happen with the gut microbiome and other of our cells that send different messages through the blood that make it to the brain. The one example I like to use a lot is regarding a condition called hepatic encephalopathy. That's basically Latin for problems in the liver leading to problems in the brain. And hepatic encephalopathy is a condition that happens when usually people with a history of alcohol abuse, although it can be other reasons, get cirrhosis in their liver, which just means their functional cells have died and been replaced by scar tissue, basically, in the liver. So the liver is very important to filter out toxins. So if you have a dysbiotic microbiome or an unhealthy microbiome, you have microbes in the gut that are producing potentially harmful and neurotoxic things, including ammonia in particular. And usually, if you have a very dysbiotic gut microbiome and a healthy, functional liver, The liver filters out almost all of that ammonia, and it does not cause problems. But if you have a dysbiotic gut microbiome producing a lot of ammonia and a dysfunctional liver, the liver can't filter it out. It remains in the blood, goes all the way to the brain, crosses right through the blood-brain barrier, and causes problems. Those problems can be mild, cognitive dysfunction, insomnia, mood changes, and they can get more and more severe, up to and including seizures, coma, and death, all from that neurological dysfunction because of ammonia and other metabolites. So that is a very, very clear example of what is happening in the gut, getting into the blood and causing problems in the brain. And I do a lot of fecal transplant. I've done thousands in my decade in practice. And the literature around alcoholic hepatitis and hepatic encephalopathy and fecal transplant is fascinating because severe alcoholic hepatitis has very high mortality rates. And there have been, I'm going to say 3, 4, 5, somewhere around that number, randomized controlled trials looking at people with severe alcoholic hepatitis and getting FMT, or randomized to not get FMT, where you have massive, massive reductions in mortality, like 3-month mortality rate of 60% down to 30%, massive reductions in hepatic encephalopathy and other problems. So changing the microbiome in humans in well-conducted randomized controlled trials absolutely can change outcomes for these people.
Wow, that's amazing. So
Yeah.
even if the liver is dysfunctional, if the gut has a good balance of good microorganisms, that
Absolutely. Yeah. So even with the dysfunctional liver, you can reduce the burden on that liver, what it has to filter out, and end up with better outcomes. And fascinatingly enough, also give FMT to those people, fecal transplant to those people, and their cravings for alcohol reduce. And in fact, you can take alcoholics with alcoholic hepatitis and give their stool to germ-free mice. And those mice are going to start craving alcohol. And then you give FMT to those humans, and they get better. And you give their new stool to those mice, and their alcohol cravings drop. So there's a big, big link between the gut microbiome, alcohol cravings, production of dysbiotic microbes, and the liver's capacity to filter out and protect the brain.
Yeah, that's amazing. Just a little side story. I had a friend who donated her kidney to another friend, and the one friend was a major coffee drinker, and the recipient was not a coffee drinker. But after she got the coffee drinker's kidney, she woke up and wanted coffee.
Wow. Yeah.
So
Fascinating.
fascinating.
Yeah.
Yeah. Okay. So for those listening and who want to focus on their health, if they don't have IBD, they might be thinking, oh my gosh, I should probably take probiotics, and maybe what can I do to take care of my liver? I mean, what do you recommend for like broad population? Should everybody take probiotics? How do we keep our
Yeah,
liver healthy?
probably. So I'm a naturopathic doctor, and we base a part of our core medical philosophy on looking at patterns we see in nature when there's health and trying to let humans copy those patterns so we can be in a healthy state. And when you look at natural populations of mammals, hunter-gatherer humans, etc., there's a lot of exposure to harmless and sometimes slightly harmful or more harmful microbes in the environment. So there is originally called the hygiene hypothesis, this idea that we need to be exposed to some pathogenic microbes in order to build a robust immune system. And there's some value and truth in that. There's a later variant of that hypothesis called the old friends hypothesis. It says, yeah, we do need to be exposed to a diversity of microbes, but they don't necessarily need to be significantly pathogenic. It can be things like good, healthy amounts of lactobacillus and bifidobacterium, and some spore-forming microbes, and some helminths in mild amounts like Necator americanus and other things. Really, exposure to these relatively harmless things can give us that preventative benefit we need. So I would say it's hard to specifically say what does a broad population need, because different individuals with different genetic backgrounds and different environments are going to need different things. But in general, I do think probiotics are an opportunity to expose our immune system to harmless microbes that are going to teach it tolerance and allow the immune system to exercise without getting overreactive. So yeah, I give my kids probiotics. I take probiotics. Probiotics are in the toolkit for most of my patients.
Okay. And you mentioned some words that people might not know. So if we're just going to go to some foreign words, because I did not know what Helminth, is it with an N? HELMINTH?
NTH.
Okay.
Yep.
So what is that?
So when you study microbiology, you learn different classes of microbes that can interact with humans. One of those classes is helminths. Helminths are usually microscopic, but sometimes just small but visible, worm-like organisms that live in the gut of every type of vertebrate on the planet. So every kind of fish and bird and primates, mammals of all kinds, they all have helminths, little tiny microscopic worm-like organisms that have evolved to live in their guts. And some of those are harmful. Some of the ones in humans can cause a lot of harm to our kidney. They can move from our guts to our kidneys or to our livers or to our lungs and cause big harm, or our brains even, and cause harm. There are tens of thousands of species that are very harmful, but there are some that are pretty much harmless. Kind of like there's harmful bacteria and there's harmless bacteria. There are some helminths that we think of as probiotic and basically beneficial for the human immune system. So I've intentionally given helminths to between 100 and 150 patients, and also family members and myself, just to try it out, because people get a little grossed out. They're like, oh, gross, worms in your body. We don't like that. It makes people think of, worms eating our corpses when we're dead. It's not that kind of worm. Really, you can think of them as old friends that live in our guts and have conversations with our immune systems to tell them not to be so active all the time. And actually, speaking of what happens in our gut and our immune system and cognitive ability, I want to mention something. So I'm genetically ApoE4 homozygous, which means, as I'm sure you know, I have somewhere between I think it's a 5 and 8 times increased risk of getting Alzheimer's in my 60s. So that's a big increased risk. And there's a guy named Michael Gurvin, who's an anthropologist, who's the biggest expert in the world at studying a group of traditional living people, mostly in Bolivia, called the Chimane. And there's an interesting story I can send you a copy of a researcher from the United States who was helping Dr. Gurvin study the Chimane, who had an uncle who had Alzheimer's dementia and really suffered from it. And so he turned his professional attention to, what about cognitive decline and dementia in the Chimane? And he looked at those who were ApoE4 homozygous, like I am, and he looked at those who did or did not have helminths. Because when you look at hunter-gatherer humans, often a big proportion have helminths, but not all. Well, what he found was fascinating, which is that those who did not have helminths and were ApoE4 homozygous of the Chimane, just like in the United States, once they hit their 60s, they had a 5 to 10 times increased risk of getting cognitive decline. So that risk was significant in their lives. Those who had helminths and were ApoE4 homozygous, like me, had decreased risk of cognitive decline in their 60s. So I initially brought helminths into my gut microbiome just to tell my patients, hey, you may think there's an ick factor, this might seem gross, but I want to prove to you that I don't think it's gross by doing it to myself. So I've done that twice. They only live 3 to 5 years in a human gut. So actually my last population died out, and I am intending to redose soon, but not just to tell people it's not gross, but in order to provide benefit for once I hit my 60s or, and going up into that time, I think it's going to reduce my risk for cognitive decline.
I'm so fascinated by that. And I'm so excited that you shared that story, because I was completely unfamiliar. I mean, I know generally gut health can impact your brain health, but I did not know specifically about helminth. and
Yeah.
now I want to try it.
Yeah, great. We can talk all about it. So really, the gut health is important, but the immune system is like the car ride that is taking the value from the gut and bringing it to the brain, or the harm from the gut and bringing it to the brain. So important to be aware of all three of those at the same time.
Yeah, it's very fascinating. Okay, I want to go. We're going to dive into more impact of gut brain health in a little bit, but I want to go back to some things that might be unfamiliar to people. You mentioned FMT.
Yeah.
Can you talk about that a little bit?
So yeah, that's fecal microbiota transplantation. Goes by some other names in the literature, but that's the most common one. And that is the practice of having patients who have a dysbiotic or unbalanced gut microbiome that's causing them harm for one reason or another. There's a lot of reasons. And then taking stool from a healthy screen donor, and because stool is 2/3 microbes by dry weight, using centrifuge and other things, strainers, to concentrate the microbial part of the stool from your healthy screened donor, and actually administering that to your patient, either through an enema, putting the microbes right into the rectum and colon where they're going to be able to grow and settle in. That's where they belong. Or sometimes we give it via triple encapsulated capsules or other things through the upper GI route. Often if we're trying to influence the small bowel also, or some of my patients are having diarrhea 30 or 40 times a day, so they can't retain an enema, so we give capsules. So that's what FMT is: fecal microbiota transplantation, transplanting microbes from the feces of healthy people into sick people to help improve their health.
Yeah, so I had heard of that years ago to help people who were not responsive for C. diff, which my mom had, but I had not heard it until I met you as a treatment for IBD. So how common is it? How well studied is it?
Well, I will say we don't have a lot of so-called silver bullets in medicine. Mostly medicine is complicated and messy and funky, and you have to try things and see what works and then try again and try again. FMT is as close as we have to a silver bullet for people with C. diff colitis as anything in the world. I've used it for that indication many times, and it is not 100% effective, but it is about as close as it gets. 95% effective, depending on how you measure it. So also it's pretty well represented in the literature for inflammatory bowel disease, both for ulcerative colitis and Crohn's, although it's more well represented for ulcerative colitis in the literature. It's in the literature for IBS. And there are inklings in the literature of benefit for people with various neurodegenerative conditions, including Parkinson's and including multiple sclerosis. I myself have used FMT with a few people with MS. And I can remember one of my first MS patients who did a series of probably about 20 FMT enemas with the stool of a friend that I helped him screen and process, who was in the early stages of his relapsing remitting MS when he did FMT. But he responded so well that except for a little numbness in the fingers and toes, all his symptoms disappeared, and his MRIs became completely clear, where they couldn't even find any traces of MS anymore. So that's just another testament to the gut-brain connection, and that particular patient was fascinating to see how much he improved.
Wow. So exciting. So exciting. I have heard stories of people who just tried this on their own. Like they just used the stool of a friend and used a turkey baster and stuck it up there. But that's maybe not recommended. What do you recommend?
It's kind of recommended. I tell patients all the time. Sure. I tell patients all the time. FMT enemas with a screened donor who's not going to pass on HIV or syphilis or viral hepatitis or other things like that. So you screen out the pathogens, you have a healthy donor, and then doing FMT enemas from that person is easier than baking a cake. Like if you can bake a cake at home, you can do FMT enemas. In fact, even if your cakes turn out not that great, you're going to do fine with FMT enemas. It is really not technically difficult, and it can be very safe and very effective to do at home. I really, really do strongly recommend using a screen donor. But no, I think DIY FMT, I've recommended it hundreds and hundreds and hundreds of times, and I, coach my patients through it sometimes, but sometimes they don't really need that much coaching because it's really genuinely not that hard. Yeah.
So what are you screening for a screen donor?
So the basics that everyone's been screening for a long time are HIV, syphilis, and viral hepatitis, and then in the blood. And we screen the stool for parasites in their eggs, for C. diff, and for common enteric or gut pathogens that could potentially harm people, like salmonella or certain strains of E. coli, things like that. So that's the basics we screen for. Sometimes, depending on the patient, especially in immunocompromised people, now we've gone to also screening for multiple drug-resistant organisms. So like MRSA or other drug resistance genes in bacteria that could make an immunocompromised person at risk later. Sometimes we're screening for CMV or EBV, depending on the stool bank. Different people do different things. So that's what I mean by screening for it. And then those are the lab tests we do, but we're also giving them a careful screening, a health history, and physical exam if indicated to make sure they don't have any autoimmune disease, any chronic gastrointestinal disease, any mood disorders, any chronic pain disorders, things like that. Most people screen out history of cancers as well, although that's a little bit debatable. And we want to make sure they haven't had antibiotics in at least 6 months and they have a healthy form stool every day. So we're looking for a very healthy person who passes certain lab test requirements.
Okay. Yes. And you mentioned earlier that with the mice that were anxious, that their fecal matter was transferred into mice that weren't previously anxious, that became anxious. So you want to make sure this person is generally healthy as well. And they've also done studies with mice where their body mass index changed, where they put,
Yeah.
I've heard people say, I need the poop of a skinny friend so that I can lose some weight.
Yeah. So I will say this. It is easy to make skinny rats fat and fat rats skinny with rat fecal transplant. Humans are not the same. So lots of things that are true in mouse or rat studies do not end up being true in human studies. So there have been 3, 4, 5, 6 studies of FMT for people with overweight or obesity. And basically what we see is there can be small reductions in body mass index, reducing overweight, in the subset of people that have diabetes or metabolic syndrome. So FMT from healthy people can make people with reduced insulin sensitivity become more sensitive to insulin. That's a good thing. But in people who don't have insulin sensitivity dysregulation, FMT doesn't appear to help them at all.
Okay. Thanks for that clarification. That's helpful.
Yeah.
Okay, so you mentioned the impact of gut-brain and brain-gut. So we call that the gut-brain axis. Do you see in your IBD patients that they are more stressed or more anxious or more depressed than the general population? Is there a connection there?
So in my practice, and also it's really been well studied in the literature, and generalized anxiety disorders and major depressive disorders are significantly more common in patients with IBD. So I've seen that, and it's also borne out in the literature.
So what do we do to address that?
There are a few layers of approaching that. And the main one that I focus on in my patients with IBD is lowering that primary inflammation that's starting in their gut, so it's not having secondary effects on mood or on many other things that can happen in patients with IBD. It can be skin disorders, can be joint pain. There's all sorts of things besides anxiety and depression that are more common in those people. But for all of those extra intestinal manifestations, or things that happen outside the intestines, reducing that primary inflammation benefits what's happening in the gut and benefits what's happening outside of the gut. So that's always my main focus. But as a doctor, one of my priorities is helping patients feel better even when that root cause isn't dealt with yet, or we're not all the way there. So working on the root cause and then also improving anxiety or depression or whatever in the meantime. So part 2 is using all the tools at my disposal to palliate a little bit, to help them feel better. So what are tools for that? I love botanical medicine, herbal medicine. And so for my patients with anxiety, I'm often using skullcap or scutularia, which is great at reducing anxiety in some people. Lavender essential oil in capsules. Actually, there's a randomized controlled trial comparing that to reduce anxiety versus benzodiazepines and finding a comparable effect. And I've found that to be really helpful for some of my patients with anxiety. Working on sleep for my patients with insomnia and anxiety can really, really benefit their daytime anxiety if they're able to get more sleep. And so we have herbs and supplements and other things for that. For people with depression, for major depressive disorders, I also love herbs. Without a doubt, my favorite one is saffron. People think of saffron as a culinary herb, as the world's most expensive spice, but tiny, tiny doses are very helpful for people with major depressive disorders, to the point where it really costs not that much, about $100 a month for an evidence-informed dose of saffron. This has been used for thousands of years. The oldest medical text in the world, an Egyptian text that we call the Ebers Papyrus, mentions using saffron as a cardiac medicine at a time when the heart was thought to be the seat of the emotions. So used for people with emotional dysregulation. And there have been, I'm going to say, probably a dozen randomized controlled trials comparing saffron to placebo, to Prozac, to other antidepressants, and finding it to have the same level of benefit on depression and actually also on anxiety as antidepressants, and statistically significantly more than placebo, except, surprise, surprise, without all the bad side effects. So SSRIs famously have a risk of lowering libido and other aspects of healthy sexual function. Saffron statistically significantly improves libido and other aspects of healthy sexual function. And it works well with SSRIs to, they work in conjunction to lower depression and anxiety more than either one would alone. And giving saffron tends to cancel out that effect on healthy sexual function and libido that SSRIs tend to decrease. So I love saffron as an herb. Love it for my patients with depression. I also use other things for my patients with depression, other herbs like St. John's wort or other things. My single favorite intervention, probably that's not herbal for my patients with depression, is another evidence-informed one. And that is, for patients who can afford it and take the time, an hour of therapeutic massage 3 times a week for a month. I know it's a lot. And then twice a week for a month, and then once a week for a month, and then 2 to 4 times a month ongoing to significantly reduce the depression associated with major depressive disorders. That's in the literature, and I've done it many times in my practice. Love it. Sauna can help, many others. So there's a million, and of course, things like SSRIs can really help as well. And I love using SSRIs sometimes for patients with GI dysfunction as well. There can be some combined benefit because serotonin is what actually causes peristalsis in the gut and moves things through the gut. So it can be helpful sometimes. And other things like ketamine therapy is a very exciting new evidence-informed treatment for patients with depression. I've referred for that and loved it sometimes. Psilocybin therapy has been explored in the literature for patients with depressive therapy, and I've referred for that as well and love it. So there's a million tools to explore in order to try and find the best ones for each patient.
You've shared some really amazing pearls that I was completely unfamiliar with. So thank you for sharing your knowledge. I think people are going to be very excited about saffron in particular.
Love it. Love it.
Yeah, that's awesome. So, okay, so I reached out to you initially because I had come across a abstract from the journal Progress in Neuropsychopharmacology and Biological Psychiatry. And it was published July 28th in 2022. And it's called Inflammatory Bowel Disease, a Potential Pathogenic Factor of Alzheimer's Disease. So I work generally in brain health and optimizing brain health to reduce dementia risk, Alzheimer's being one of those dementias. And that's the one that's most studied. So in that abstract, I have not read the whole paper, and you're not one of the researchers on this, but I thought I would pick your brain a little bit about you've touched on it, but how could what's going on in your gut impact Alzheimer's disease, and how could people with IBD be at greater risk for Alzheimer's? And can we look at some of those things that might be causative or contributory factors?
Yeah. So I skimmed through the article that you sent me, and the authors, even themselves, just kind of have guesses about what that mechanism of action is. But a lot of it is the same stuff we've talked about. We know that people with active inflammatory bowel disease tend to have dysbiotic or unhealthy, unbalanced gut microbes with inflammatory type bacteria predominating, anti-inflammatory bacteria that produce short-chain fatty acids like butyrate being in minority and lower proportion than they would be in people who don't have active IBD. So those inflammatory metabolites can absolutely move into the blood, and some of those can cross the blood-brain barrier and directly cause inflammation in the brain, increasing risk for dementias. The authors wonder as well, could there be a neurological connection, a neuropsychiatric connection between the gut and the brain that would be mediated through the vagus nerve? And so I don't think anybody has studied if risk for Alzheimer's disease decreases in IBD patients who are well controlled. But I think the obvious assumption is yes, it would, unless otherwise proven that it doesn't. So I think it's that primary inflammation, that primary dysbiosis that are then connected to the brain through that gut immune system brain axis.
Right. Yeah, helpful. When I was researching, is there a correlation between autoimmune disease and dementia? I found one study that was done in the UK. That is one really good advantage of having universal medicine, where everything is in one database. So you can look at large numbers of people. And what they found is that people who had been hospitalized because of their autoimmune disease had about a 20% increased risk of, I think that was looking at Alzheimer's in particular. But I was like, well, that's just the people that are hospitalized. If you're addressing root causes of the autoimmune disease and you're well and you're not hospitalized, would your risk go down? And my assumption is yes. So that's what I'm going with.
Not surprised. That makes sense, that people with higher levels of inflammation, in fact, levels that are so high that they end up in the hospital, would then be at higher risk of neurological conditions. Yeah.
So we haven't talked about diet at all. So if we could go there a little bit, I would appreciate it. I know it's huge. There's huge variation in how you use diet to treat IBD. But if we're just looking at the standard American diet and how we can reduce inflammation, how we can increase the short chain fatty acids, what would you say could be helpful generally?
Well, Michael Pollan has written about food a lot and health, and his brief summary of how to eat a healthy diet, I think, is the best one I've heard. And it goes like this: eat food, and by that he means actual food and not edible food-like objects. Eat food, not too much, mostly plants. And I think that's great advice. If you try to eat similar to how your great-grandmother would have eaten, or somebody's great-grandmother would have eaten, by reducing processed foods and eating more whole foods, including and especially reducing the processed food known as sugar, and eating a variety of things with a lot of plants in there and not overeating. That is the single best way to have microbial diversity and lots of good, healthy, short-chain fatty acid production in the gut. There are some amazing microbiome researchers, the Sonnenbergs. They're a couple, married couple who are both PhD microbiology researchers. And their research has advocated eating at least 30 species per day. So you're consuming that many different species of plants in a chunk of time in order to increase microbial diversity and healthy short-chain fatty acid production.
Okay. 30 different species per day. And maybe not the same 30 over and over and over and over.
The more diversity the possible is sort of the general trend. Yeah.
Okay. So that could be hard for some people if they're used to eating like cereal for breakfast and a sandwich for lunch and pasta for dinner.
I'm sorry, I misspoke. It's not 30. I said 30 species per day. It's 30 species per week. So that's a lot less challenging.
Okay.
And allows you to spread that diversity out. And same thing, maybe not the same 30 species week after week, but 30 species a week. So in our household, sometimes, I'll have one of the other adults in my household bring me a smoothie and be like, got 9 species in there. It's like, all right, making progress towards our week. So the more diversity you can get, because every plant is a rich treasure trove of healthy phytochemicals and antioxidants, and they all offer different treasures. So having strawberries at one point and blueberries at another point and other colorful fruits and vegetables in your diet, and even grains and beans for people who tolerate grains and beans, which I think is most of us. The more diversity of those whole plant foods, the better. And we aim for just 30 a week.
Okay.
Which is doable.
That's doable. I can connect to 30 a week. Yes. And suggestions for other moms out there. Sometimes make your kids smoothie in secret so they don't know what's in there because they can't taste it. Because I can put in hemp seed and flaxseed and chia seed and then kale and spinach. And he doesn't have any idea because he just tastes the strawberries and blueberries and almond milk.
Like we're 8 species that you named just there. Yeah, that's a great smoothie.
Yeah. Okay. Awesome. So what else do you want to share that we haven't covered? Did we forget anything that's important?
Well, we've talked about a few different aspects of neurological health, and we've touched on Alzheimer's and dementia and cognitive disorders, and we've talked about MS. And I just want to maybe bring up a hypothesis of mine that's not proven in the literature yet. But there's a fascinating observational trial of Helminthic therapy, or of helminths, that happened in Argentina. So around the turn of the last century, in the 2000s, the Argentine economy really collapsed and they went into a depression for a while. And it was so bad that the government was underfunded. And for a while in Buenos Aires, they were unable to maintain infrastructure enough to keep sewage water out of drinking water. So people who were drinking from the tap were routinely being exposed to microbes from sewage. And that led to a bunch of outcomes. But one was that people were more likely to be exposed to what we often call parasites, protozoans, and helminths. And there was an Argentine neurologist, Dr. Correal, who was familiar with the literature about helminths and autoimmunity and neurodegenerative conditions. He said, well, I'm a neurologist. What about, because here's a fascinating thing about MS. Every country that has, I think the number is at least 10% of the population have helminths. That's the number where MS shoots to almost nothing. Now, correlation doesn't always mean causation, and those tropical and subtropical countries that have higher prevalence of helminths also have more sun exposure and more higher vitamin D levels, and tend to have a bunch of other things, tend to be countries with lower economic resources, and so that means people tend to eat more whole foods and have to be less sedentary for their work and other things. There's all sorts of things, but it is unknown if it's causative, but a certain prevalence of helminths in the population is associated with almost zero levels of MS. Dr. Coriell is familiar with this. So he said to his patients with MS who started to have blood markers that showed that they had parasites, he said, if you want, we could not treat you. We could not treat these helminths or these parasites, was the term he used, unless you start to develop symptoms that you don't like. And so of all his patients with multiple sclerosis, I think the number is 12, said, yeah, let's hang on to these. Don't give me the easy, safe drugs that get rid of these helminths. I'm gonna keep them on board. And he followed those patients for 5 years. Pretty good long period of time. And he tracked them in a lot of different ways, including looking at MRIs, looking at how many flares they had, and looking at the EDDS, which I'm sure you're familiar with. I think it stands for the Extended Disability Status Score, and it's a 0 to 10 scale. 0 is no symptoms at all, and 10 is death. And so it moves through increasing levels of impairment, including being needing assisted walking, being bedbound, eventually till 10 is death. And so when he compared the group of his patients who did not have old friends living in their gut to those who did, at 5 years, there was a difference of 3 points out of this 10-point scale in the extended disability status score between these two groups. 3 points is huge in this 10-point scale. And in addition, there were big differences in number of new and emerging lesions on MRI of the brain and spinal cord, total lesions, and flare activity. Big differences. And a few patients had diarrheal symptoms or other things, and they said, I do want to go get rid of these helminths. So they took the easy, safe drug that kill the old friends off, and their risk immediately very quickly jumps to the level of people who did not have helminths. So that was very, very exciting. And a few people said, let's see if we can replicate this. So there have been some clinical trials of intentionally giving helminths, including Nicator americanus, the New World human hookworm, my favorite helminth, to people with MS. And the results were underwhelming. Some of the trials were too short to really see benefit, I think, so it was a bit of a waste of a trial. But other ones that were longer saw only minimal benefits. And so here's where we get to my own hypothesis. Because these people were being exposed to old friends in the context of accidental exposure to sewage water, they were basically getting FMT, or fecal microbiota transplantation,
right,
that bacterial surge, at the same time as they were giving helminths. And so no one has ever done a clinical trial where they take people with MS and they give them helminths and fecal transplant at the same time. And my hope and thought and theory is that you might be able to replicate those massively robust findings in the observational trial in Argentina if you did both of those things at the same time. So I would love to encourage a group of people with MS to try both of those therapies at the same time. But they're both, a little, there's some ick factor associated with each, and there's some expense associated with each. And so I haven't been able to, make inroads into getting a group of people to trying that at once. But if I had MS, I guarantee you I would be doing both of those therapies at the same time.
Well, maybe I'll volunteer to be your first case study.
Amazing.
That'll make me a better health coach who's coaching other people in your practice. For people that don't know, I haven't shared this. I'm currently working with Dr. Mark Davis in IBD solution. And we'll talk about that in a minute for people that want to find you. But yeah, I couldn't better relate to patients who are going to do FMT if I've been through it myself.
I'm excited to continue that conversation for sure.
Okay. So how can people find you, Dr. Mark?
Okay, so the only place I practice at this time is at ibdsolution.com, where Laurel has kindly and excitingly started to work doing health coaching for our patients. And we only treat patients with inflammatory bowel disease. The major inflammatory bowel diseases in the United States, ulcerative colitis and Crohn's. So it's myself and 3 naturopathic doctors, all of whom did residencies with me and are all brilliant in their own right. And we're only taking on new patients who have ulcerative colitis or Crohn's disease and are in one of the 9 states where we're licensed. You can find out about those states and other things about the program at ibdsolution.com. So excited. We've only very recently launched. And one interesting thing about the program is we are asking kind of a lot of the patients. We're asking them to take a couple of minutes each day to fill out a symptom survey in our electronic health record system to keep track of their symptoms every day. So we can monitor them every day and keep a lot of data about how they're doing, and then to test inflammatory markers in stool and blood about once a month. So our goal is to, A, provide the best care in the world for patients with inflammatory bowel disease using a combination of pharmaceutical medicines in states where we're licensed to provide that, and herbal medicines and fecal transplant and Helminthic and everything that's the right fit for that patient. But A, provide the best care for people with IBD in the world, and B, provide the evidence that we are providing that level of care and continuously get better at providing care. We want to raise a new bar for how good of care people with IBD get and bring everyone in the world along with us as we're doing it. So it's kind of an audaciously large goal, but we're very, very excited to get launched on it.
Yes, it is very, very exciting. And I love that you're from the very beginning, starting off with documenting how people are progressing. And I'm so excited for you, and I'm so excited to be part of the practice.
Me too.
Yay. So this has been an absolute pleasure hanging out and chatting with you today. I greatly appreciate you and your time.
Same. Thank you.